Dr. Hannah Imlay. So Dr. Imlay is an assistant professor of medicine at the University Utah School of Medicine, where she directs the Immunocompromised Stewardship Program and is the associate medical director of the Antimicrobial Stewardship work at the University of Utah Health and Salt Lake City Veterans Affairs System. So we are so privileged to have Hannah here today. And go ahead and turn it over to you.
Thank you very much, and thank you for the organizers for having me. I actually do know where Bloomington is. I grew up in Champaign, about 54 minutes south of here. And middle schoolers really like the Avantis across from the airport. How's this? Better? All right, so today I'm going to talk about rebuilding antimicrobial stewardship in a post-pandemic era. What I didn't know beforehand is that I should have called this, we go back to thinking about urinary tract infections. I have no disclosures in the last 3 years. Previous to that, I was the principal investigator for one of the remdesivir trials. There we go. And today I'm kind of going to split this into two major parts. I will be talking about COVID, and I am sorry. The first part, I will really talk about what did things look like during COVID for stewardship teams. And then the second part, I'm going to kind of take an optimistic take of what do we take away from the pandemic and things that frame our ongoing work, and specifically how these have changed our programs at the University of Utah. So what happened with stewardship teams during the COVID pandemic? And I think the most striking thing is that everybody rapidly adapted to new jobs, new roles, and those included things like coordinating outpatient COVID therapies, coordinating and restricting inpatient COVID therapies, and creation of a lot of guidelines and recreation and reamendments, et cetera, for COVID-specific therapy, vaccination, and diagnostics. And I think at one point we were even working on bed flow diagrams, and then implementation of all of the above. And this is a survey from the Michigan Hospital Consortium of 51 hospitals. But you can see here, everything highlighted in blue was additional duties reported by stewards that took a major effort and a major amount of their time. Orange was a medium effort, and then gray was the small effort. And you can, number one, see how many things are listed here. But you can also see that among the major interventions, among the things that took a lot of blue time, these included treatment guidelines, drug and vaccine allocations, and education of teams. And these new roles required interdisciplinary coordination with many different institutional and non-institutional areas, and really relied on a lot of pre-existing stewardship networks, which was kind of a natural extension of the communications we were already having with different provider groups and different administrative groups, and then forged some new relationships as well. This all highlights that the role that stewardship really played with communication, and I think will play an ongoing role because we are used to communicating in multiple networks of the healthcare system, and this is applicable to many new challenges that our healthcare systems face. At the University of Utah, we actually created a COVID pager within a few weeks of the pandemic that was staffed by 4 physicians. And then the stewardship team actually for about 18 months. And this was just a pager that was available. It was used for a variety of things, but early pandemic, we used this for diagnostic stewardship. So one of the physicians had to put in an order for every rapid test because of testing shortages. We used it for therapeutics, so all approval of any COVID therapy went through that trial and also coordinated with clinical trials that were recruiting at the time. And then questions about everything from anybody about, I want to pick your brain on what the vaccine safety is like type of stuff. But really was a resource that improved communication that was really lacking. And in a large healthcare system, and I suspect many of you feel this as well, communication is like the single hardest thing to distribute from kind of the top of the healthcare system out to everybody that actually needs to know that information. So what things impacted stewardship initiatives? This is from that same survey. And the major thing here was the stewardship time that's now spent on COVID. That's the top entry there. Other things included needing to deploy ASP physicians or pharmacists to other roles, or lack of availability of other resources that are necessary to stewardship functioning, such as IT or microbiology, that were then taken up in new roles themselves. And all of this led to the inability to really fulfill pre-pandemic traditional stewardship-focused tasks. So for us, we are a large healthcare system. We're not the largest healthcare system. I know University of Michigan and Northwestern are here, but we have a 5-hospital system that approaches 1,000 beds, with new hospitals coming, as well as community health centers and urgent cares. And at the beginning of the pandemic, our FTE was 0.6 MD FTE and 1 pharmacist dedicated to stewardship at any given time. And we had a fairly active stewardship program, and you can see all the daily interventions that we were performing on the left, which included pretty active prospective audit and feedback of our inpatient services. But during the pandemic, because of these additional roles, these really decreased to reviewing positive blood cultures and managing all restricted antimicrobials via the COVID and stewardship pager. So what happened with stewardship during the COVID pandemic? Well, I think this was highlighted previously today, and I think it's something that we all feel deeply. But we know that there early in the pandemic was a high rate of antimicrobial prescribing. 75 to 80% of patients with COVID-19 received antimicrobials, which we now know in retrospect was a gross overestimate of the proportion of patients who needed antimicrobials. And we also have noticed increases in resistant organisms. And so this is from the CDC special report on antimicrobial resistance from 2022, and shows an alarmingly high increase in resistant infections during early COVID, during early to middle COVID, really. And also has been demonstrating increases in hospital-acquired infections, which is a trend that was sustained at least through the end of 2021. And specifically, these HAIs are particularly affecting COVID patients. So we have our work cut out for us as we reinvigorate our stewardship programs and refocus on antimicrobial resistance and other kind of more traditional stewardship activities that have less to do with COVID. So what does this look like post-pandemic? And I would first push on the issue that we are in fact post-pandemic. Number one, COVID is still ongoing. But number two, we are not new to pandemics. And really the first pandemic that stewardship programs are created in response to was the pandemic of antimicrobial resistance. So really we are talking about 2 pandemics. What do things look like after, with the ongoing pandemic of resistance and after the major push of COVID-19. These statistics were already cited today even, which is acknowledging the massive number of antimicrobial resistant infections that occur each year and the massive number of deaths that occur from this as well. And we know that subsequent public health crises like the COVID pandemic, but also including things like natural disasters, famine, et cetera, will further worsen the threat of antimicrobial resistance, and that this high rate of resistance will be borne primarily by low and middle income countries. This actually preceded the COVID pandemic, but the United States National Action Plan was launched in 2015, and there was a specific advisory council on combating antibiotic-resistant bacteria, including combating antibiotic-resistant bacteria during the next pandemic. And this included specific recommendations that included a focus on stewardship, infection prevention, and other hospital-level interventions. So let's talk about some of our COVID pandemic legacies, really an optimistic view of what we will take away from this and how this will change stewardship as practiced in our own hospital systems. So I brought this up earlier, but really these communication networks are really kind of the biggest thing that we bring to the table. And I think this will be one of our ongoing legacies, is our ability to communicate throughout the health system. And this includes relationships with institutional leadership, as well as relationships with clinicians and different clinician groups. This was published before the pandemic, but essentially was a survey conducted among stewardship programs that identified staffing resources and self-reported effectiveness of their own stewardship program. And then the authors used the data to inform recommendations for appropriate stewardship needs. And this was really based on hospital size. And what they noted was that, again, this was conducted pre-pandemic, but each 0.5 increase in FTE support was associated with a 1.5-fold increase in the odds of demonstrated effectiveness. And this was essentially mediated by the ability to do prospective audit and feedback, or reviewing all patients of a specific diagnosis who are on antibiotics or on specific antibiotics. You can see here this table that was constructed based on pharmacist FTE needs or pharmacist FTE recommendations and physician FTE recommendations by bed size of the hospital system it's serving. But it's important to note that these benchmarks were established and created prior to the pandemic, and with higher health system work level may require more actual support and more stewardship time. And we use these benchmarks as well as our demonstrated effort during COVID-19 in our hospital system to advocate for our own team and increased our MD FTE to 1 and 2.5 pharmacists. And so we better do something with all those people. And the biggest thing to do here is to expand our stewardship footprint, which is something that is surveyed at our hospital and tested at our hospital by queries of everyone in the community, as well as at our different hospital locations by our hospital accreditation surveyors. As I mentioned before, our COVID work really touched on kind of new populations that the stewardship team had not been involved with previously, as well as new interventions, and really identified patients that used a lot of antimicrobials and had a high burden of antimicrobial resistant infections. But because they did not represent the lowest hanging fruit of stewardship, we had not had a large stewardship footprint in those populations. We did have some, but not large. And these included outpatient areas. So particularly, we did a lot of COVID work in the urgent care and ED, and are currently doing work targeting respiratory viruses, including peer comparison, use of peer comparison data to inform practice. Immunocompromised patients, and so this is my specific area of work, but really establishing guidelines, prospective audit and feedback to decrease antibiotic prescribing in this population. When we talk about urinary tract infections, that really means UTI diagnosis and treatment of asymptomatic bacteriuria in our kidney transplant population, which is a big deal for us, it turns out. And then areas of the medical system with a long length of stay. And for us, that really means our rehab hospital when we talk about inpatient spaces. And so we are now developing, UTI guidelines, asymptomatic bacteriuria guidelines, particularly among patients either with indwelling Foley catheters in our rehab hospital or who have spinal cord injuries, which again is not the lowest hanging fruit, but identifies a clear need and a clear consumption of antimicrobials at our hospital. So what other pandemic legacies will we see, particularly at the University of Utah? Part of our COVID work was a lot of coordination with state level partnership. And we have 4 major health systems in the state of Utah. We are lucky in that way. And so part of our COVID response was trying to deal with federally allocated drugs and consumption of federally allocated drugs differentially by different healthcare systems. And so representatives of each of these healthcare systems got together, and part of our COVID work was establishing criteria originally for remdesivir and then later for the use of monoclonal antibodies that would be clear, data-driven, consistent throughout the whole state. And so this was a state level criteria for remdesivir use, where each inpatient hospital would use these same state level criteria because remdesivir was on shortage. And then happened again for monoclonal antibodies, which expanded to include issues to do with equity and operational hurdles and infusion capacity. And this is what our state website looked like. We used some of our data from the neighboring healthcare system, Intermountain Healthcare, to develop a calculator that identified patients at highest risk of complications and therefore patients at highest risk, at highest benefit of monoclonal antibodies early in COVID. You can see here, this is a calculator that was posted on our state website. All healthcare systems used this and did not deviate from this. And based on the scoring system, as well as some of the EUA criteria, patients could access this website, and then you can't see all these things, but at the bottom, there was a variety of phone numbers or ways to contact any kind of healthcare facility that had the infusion capacity in the state. So what does the state participation look like going forward? We know COVID therapies are no longer federally allocated at the health system level, and we no longer have any monoclonal antibodies. That makes things easier, but this team was reassembled to discuss tecovirimat at the time of the monkeypox really spike in cases, and other resources that are allocated by state at the health system level, and provides opportunities for state level work with antimicrobial stewardship interventions, kind of targeting more things like UTIs or CAP, et cetera. This state level partnership was also an opportunity for consideration of equity. So you can see this is our calculator again. That red box is around non-white race or Hispanic or Latinx ethnicity. And if a patient qualified for that, they added to their score for this this risk calculator. And this was very consistent every time we looked at our data. This was repeatedly and consistently a major risk factor for poor outcomes, and that's why it wound up in our scoring risk assessment. This also allowed the opportunity to address low uptake and lack of access to healthcare. And so our hospital level nursing care team performed prospective outreach and prospective review of all positive COVID tests, and then was able to actually use this risk score calculator to identify high-risk patients and reach out to them prospectively. And this, we can also measure it. This measurement also was things we did during the vaccine rollout to make sure that we were accessing and providing vaccines equitably around the state. Lastly, we collaborated with community representation and provided information sessions in a variety of languages, including informational papers in a variety of languages for monoclonal antibody infusion. And then lastly, I think I said this early in the talk, we know that COVID is not done. I think we generally now kind of consider the pandemic over. And so I like to refer to this as endemic stewardship involvement and endemic preparedness. Which essentially means that the public health interventions, the public health resources have by and large ended, and a lot of the emergency use resources are no longer there. We have a lower level but consistent threat, and we know that we need to continue to provide resources for consistent treatment and testing operations, but this by and large now relies on health system level interventions, which also has to consider things like supply shortages. Other requirements include the ability to coordinate outpatient resources, and which very much involves our stewardship team, as well as the sustainability of interventions, and then ongoing communication deficits. And as I mentioned before, our COVID pager transitioned after about a year to our antimicrobial stewardship pager, which continues to help people address COVID relevant questions, because again, communication has been by and large in my practice, the hardest part of working through a pandemic. So this is a brief review on how did the pandemic change our stewardship program. And I think the pandemic uncovered many needs, particularly an expansion of stewardship roles. It uncovered needs for addressing higher antibiotic use and higher antibiotic resistance and increasing rates of HAIs, and provided a lot of pandemic opportunities for antibiotic stewardship programs as we define post-pandemic stewardship or ongoing endemic stewardship. And with that, I will take any questions.
Any questions?
Thank you. Sorry. Do we know if we're ever going to have like a universal tool? Because I know over COVID as a new IP, that was a great time to get a new job, right? Was that I was getting some things from Illinois and Indiana, and your state actually, Colorado had some great things. I stayed away from California. They were kind of scary. But as far as everyone was inventing something else, I know that our health department gives us great tracking tools, but there are also better tracking tools out there. So I guess much like the PTINR, are we ever just going to speak the same language, and how can we make that happen?
I'm happy to yell, but I think this is probably better. I think that's a big trend that we're seeing now, is the push to make things bigger and bigger and bigger, to make things state level and then to make things national level. And I think from the perspective of, the public health impact of stewardship programs, that's absolutely necessary. And I think that trend is continuing. And we see that in the push to report AR data in addition to AU data, for example. at the national level. I do think that their antibiotic prescribing is extremely cultural. And your local impact on antibiotic prescribing, on your prescribers, and on your patients will always be a local thing because it is also strongly cultural. And so I think there will be both things at play. Number one, intensification of local stewardship programs that know their doctors, that know their prescribers, and that know their patients, as well as the onset of more and more national and state level tools.